Good afternoon, everyone. Welcome to the HL7 Da Vinci Community Roundtable. Today's session is Building Reusable, Scalable Prior Authorization Tools, a case study in policy digitization and HL7 Da Vinci DTR implementation. My name is Casey Thompson. I'm the program coordinator for the HL7 Da Vinci project, and it is my pleasure to open today's community roundtable. Before we get started, I just need to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. Today, we are pleased to share Da Vinci program updates and formally recognize our 2025 Da Vinci champions. Following the program updates and champion announcements, we will transition to our featured session, Building Reusable, Scalable Prior Authorization Tools, a case study in policy digitization, and HL7 Da Vinci DTR implementation, presented by the Blue Cross Blue Shield Association and Itiliti Health. In this session, you'll hear how standardized HL7 FHIR questionnaires can accelerate adoption of prior authorization interoperability through a real-world case study. The presenters will discuss how Blue Cross Blue Shield Association is digitizing and centralizing reference medical policies and FHIR questionnaires aligned with the HL7 Da Vinci Documentation Templates and Rules DTR Implementation Guide. You'll also learn how this reusable approach reduces duplicative development, supports CMS 0057 readiness, and improves consistency in provider documentation while preserving flexibility for local implementation. The session will cover how policy digitization enables questionnaire creation, considerations for distributing standardized DTR questionnaires across diverse environments, and governance and quality practices needed to support implementation at scale. The result is greater efficiency for providers and a more streamlined path for payers to meet CMS 0057 requirements. Please join me today in welcoming our presenters. Dr. Rajia Hashmi, the Vice President of Clinical Affairs at the Blue Cross Blue Shield Association, Michael Lunzer, the co-founder and CEO of Itiliti Health, and moderator Alex Goss, Program Manager for the HL7 Da Vinci project and Senior Consultant at Point of Care Partners. We will post the recording of today's webinar and slides on Da Vinci's presentation page on Confluence. Da Vinci's communications lead, Leslie Amoros, will be posting links in the chat box to assist with locating that page and other resources you may find of interest. We ask that you please use the question feature to submit questions, as we've limited the chat feature for us to push key details to you and to enable you to download the chat box and save those links. We've also muted lines to aid our recording quality. And finally, we sincerely appreciate your survey feedback solicited at the conclusion of the webinar or the moment when you depart the webinar. Our next Community Roundtable session is scheduled for August 26th. Registration details will be posted on the Da Vinci calendar, and there's a link on this slide to all of our previous Community Roundtable recordings. Upcoming events, we have the WEDI Summer Forum coming up August 10th through 11th in Chicago and virtually. And we have HL7 events, the CMS HL7 FHIR Connectathon taking place July 14th through 16th. That Connectathon is free to attend and is virtual. And the HL7 40th Annual Plenary Working Group Meeting and Connectathon, September 19th through 25th in Rockville, Maryland. We have links to all of these events and more information on the slide. Okay, let's dive into a few program updates. So let's do a quick review of our 2026 program priorities. This year, we will continue advancing our core functions with a strong emphasis on supporting our implementers, both directly and through our industry partners. We'll be putting significant effort into expanding our piloting activities, strengthening implementer engagement, and promoting shared learning across the community. These activities are essential to ensuring real-world success. We also plan to explore new and improved methods for engaging stakeholders in the implementation guide development process. Alongside that, we hope to develop a rubric to help us assess investments in IG development and determine adoption readiness. This will give us a more structured way to prioritize and understand where our resources can make the biggest difference. Our work will continue to involve close coordination with our industry and federal partners, and it's important that we remain responsive to relevant policy opportunities as they arise. In addition, we want to continue elevating the awareness of FHIR and collaborating to help the community better understand the value of FHIR and the meaningful progress all of you are driving through DaVinci implementation guide development and piloting. Now, there are resources listed on the bottom of this slide that you may find useful. There's a link to our DaVinci in Action page where you can see all of the DaVinci guides, who's implementing them to date. Our DaVinci LinkedIn page where you can learn and hear more about all things DaVinci, and our YouTube channel with recent recordings along with our industry statements and updates. Now this slide shows where all of our DaVinci implementation guides currently sit in terms of maturity and their STU phases. There have been some updates, which I'll share on the next slide. So we've had a lot of movement on the burden reduction side. In March, we've officially published several of our implementation guides, including the Coverage Requirements Discovery or CRD guide, Documentation Templates and Rules, DTR, Prior Authorization Support, also known as PAS, and Health Record Exchange, known as HREX. PCT also published a technical correction IG update in March, and coming soon, we're moving forward on the PDEX side of the house. We have an STU update related to provider access coming very quickly. We look forward to bringing you an update once this is published. And risk adjustment balloted in May, which included adding new operations, simplifying measure reports and remarks, and updating guidance so data can be submitted with a standard post request. These publications should be available very soon, and we look forward to sending you those updates. And more information about all of these updates can be found on this slide. DaVinci has been very busy preparing for the upcoming CMS HL7 FHIR Connectathon in July. We're holding 4 DaVinci tracks at this upcoming Connectathon, a burden reduction track, including CDEX, patient cost transparency or PCT track, a PDEX track, and a PDEX PlanNet track. In addition to that, our PCT group is holding a short high-impact clinician session to help shape the future of patient cost transparency and their workflow. We have information to all of those track pages, as well as information to register for this Connectathon if you want to participate in any of those. DaVinci's final response to the CMS 0062 proposed rule is now posted on DaVinci's project resources page in Confluence. We want to thank all of our members who contributed their time and effort to help us coordinate this response. You can also view more about this response at the last 2 community roundtables, which covered more information within this rule and how it impacts DaVinci. If you're interested in learning more. Okay, let's move on to our DaVinci Champions. Now, the DaVinci's Champions program was created in 2020 to recognize and celebrate the talented problem solvers advancing interoperability within the industry. Each champion has been nominated by their peers for their outstanding contributions to advancing value-based care and supported real interoperability initiatives. Now, nominations for 2026 is currently underway. If you know someone who should be a DaVinci champion, please use the link to submit your nominations. All nominations are due by October 31st. Now it is my pleasure to announce our 2025 DaVinci champions. Their achievements reflect the collaboration, expertise, time, and commitment required to drive meaningful transformation across the healthcare system. Through their efforts, they help foster the culture of innovation and partnership that is at the heart of the DaVinci Project and our shared mission to improve healthcare through interoperability. So on behalf of the HL7 DaVinci Project and the entire DaVinci community, I am honored to recognize these champions. So join me in congratulating them and celebrating their accomplishments. Our first champion is Chris Chaffee, IT Business System Analyst, Senior Advisor at Elevance Health. Now, Chris is noted in his nomination as a highly engaged contributor across DaVinci use case calls. He actively shares insights with HL7 work groups and others, strengthening cross-community collaboration. He's a strong advocate for burden reduction and is committed to ensuring implementation guides are practical and usable. Congratulations, Chris, and thank you for all of your hard work to support Da Vinci. Our next sorry about that. There we go. Our next champion is November Valentine, software developer at Epic. Now, November is noted as a consistent presence on burden reduction calls with a clear understanding of each need and the ability to explain it in a way that deepened group understanding. Always composed, with a focus on finding solutions through thoughtful listening and meaningful responses to others' input. Now, I can personally second this, as the same experience holds true for me when I attend burden reduction calls with November. November's input is extremely valuable at advancing the guides and efforts at Da Vinci. Thank you for all of your contributions, November, and congratulations. Okay, now we'll move on to Jason Vogt, Manager of Development Interoperability API and Structured Documents at Meditech. Jason is recognized for his active participation in frequent connectathons, especially within the burden reduction track, and for his involvement in groups that extend beyond Da Vinci, including the US Realm and FAST communities. Thank you, Jason, for your continued contributions to Da Vinci and for advancing health interoperability and supporting value-based care. Congratulations. Our next champion is Lorraine Dew. Now, before Lorraine retired in 2025, she was the Director of Health Informatics and Policy Group under the Office of Healthcare Experience and Interoperability at CMS, and we all greatly miss her valuable expertise. She was always willing to roll up her sleeves and participate in the work of interoperability and value-based care. We hope you're enjoying retirement, Lorraine, and we honor you for all of your contributions. Congratulations. Our final champion is Derwin Day, Health Information Manager at Healthcare Service Corporation, HCSC, now retired. Derwin played a pivotal role in helping to establish the Da Vinci project. He recruited payers, providers, and HIT vendors as founding members. He was also widely recognized in his nominations as a cross-community bridge builder, connecting HL7, X12, WEDI, CMS priorities, and payer operations in a way that had lasting impact. Now, we are deeply saddened to share that Derwin recently passed away. He was aware of this award prior to his passing, which makes this recognition especially meaningful. And we are honored to recognize his contributions and the vast legacy he leaves behind, particularly within the Da Vinci community. I want to take this time to congratulate all of our 2025 Da Vinci champions. We appreciate all of your hard work and the efforts to move interoperability forward. It is truly an honor for me to work alongside such an incredible group of people, and it's one of my favorite parts of this role. Okay, speaking of incredible people, let's transition to our featured presentation, Building Reusable, Scalable Prior Authorization Tools with a Case Study in Policy Digitization and HL7 Da Vinci DTR implementation. As a final reminder, please be sure to use the Q&A box to submit your questions so we can keep the chat open for information sharing. Okay, Raja, I will turn it over now to you.
Thank you, Casey. It is a pleasure to be here and a little bit intimidating to be here, given that I'm in the midst of very knowledgeable technology partners. And I, as a physician, don't know anything about technology, but I do understand the fact that the work that you all are doing is going to make the experience of getting care in the system much, much better. And it is valuable work. And so what I'm going to cover for you is the clinical and policy side. And Michael Lunzer, the CEO and founder of Itiliti Health, is going to show you the technology delivery side of it. We present together on purpose because neither the clinical piece and the policy piece that I'm going to talk about nor the technology works alone. We have to partner to deliver this improvement together. So the short version of what you're going to hear is that, one association, so we're a federated system of Blue Cross Blue Shield plans, over 30 plans. And what we're talking about is over 700 medical policies. and how we brought them together to be consistent, and while also sticking to a very important principle that's important in our system, which is that care is local, and the ability to customize care locally is very important. So we're standardizing medical policies, standardizing questionnaires, but allowing local control and local change. And so that's what we're going to speak about today. And so let me be clear right up front that, a prior authorization, as is portrayed in the media and elsewhere, is not the villain. Done well, prior authorization keeps the care to be evidence-based. It protects members from harm, and obviously it helps us with affordability. So the purpose of prior authorization was never the problem. The problem was how we went about it, the plumbing of how the system worked. And so, fax, phone, the portal, sitting and waiting for a response. Everyone in this room has had that experience, right? You've experienced it as a family member, as a patient, or you may have, and you've experienced it on your work side. And CMS 0057 gave us the deadline, but really the case for fixing prior auth was always there, right? We need to create a system that has less rework for everybody involved, less friction for the provider, less anxiety, and less friction for the patient and their family. And ultimately, what we want is the topmost evidence-based care and decisions and support in a very timely manner. And so that's the problem we're collectively looking to solve, and that's the problem Michael and I were working on solving. And so that's what we wanted to share with you. And look, you know what a DTR is. When we started out this process, had to learn what this acronym stood for. What is a DTR? But a questionnaire is only as good as the policy underneath it. So what our reality was that our questionnaires lived in HTML and PDFs. And so if a questionnaire was built based on a PDF or an HTML, it's really being built for someone's memory or someone's interpretation. And the likelihood that there will be drift is very high. And that's, in fact, what we experience today. We published the reference medical policies centrally, but as policies get implemented in the various plans, we notice that there is drift. Now, the thing that we have to be prepared for is if that was the method we went forward with, then when everything is automated and at scale, what we would find is the evidence of drift at scale. And that's what we needed to protect the system against. And we made some very deliberate choices and very thoughtful and carefully planned choices. So as we digitized our criteria, the criteria was digitized using rules, not generative AI. Why? Because in a regulated environment, the criteria have to be exactly as the committee of physicians and practitioners approved it to be. It cannot drift. It cannot change. Things have to be auditable. They have to be traceable. They have to be defensible on appeal. And so close enough wasn't going to be enough. It has to be exactly what was the intent. And that's why we didn't go with generative AI as we created the questionnaire. It was rule-based. And then once the policy was structured, what happens is it stops being a document just sitting on a website. It, in fact, becomes a tool that you can use to run decisions on. And so that's what we are doing. So think of it as 3 layers. At the Blue Cross Blue Shield Association, we author the reference policy. We do it once. Michael's technology and tool and team then converts that into a coded policy and into a questionnaire. Now, every plan in our federated system has the right to review and modify anything along the way. So they can modify the policy, and then the questionnaire gets modified. So the third layer here is the layer that a lot of folks underestimate. And that's what I referred to before, which is standardization is important, but the ability to accommodate for local practice and the ability to then convince 32 independent Blue Cross Blue Shield boards that the plan is doing the right thing is important. And so that is why our approach was very deliberate. We built the guardrails, but we also built it such that, let's say a local plan changes a policy, a particular nuance, a particular word, a particular requirement, then the questionnaire must follow. And so, our experience is that this is a lot of work. And if you take one thing home, it would be start with your highest volume services, build the muscle before the mandate begins in January. And so, there were certain non-negotiables. And, the non-negotiables were that we're going to digitize only once. Every policy would have a DTR questionnaire. And the compliance to the clinical criteria approved by the committee had to be 100%, 99, not 98, 100%. And the questionnaire and what the plan published had to be the same thing. So we needed a human readable policy. That questionnaire then created, they needed to be in sync, and they needed to continue to be in sync as things evolved. And that the half-life of medicine is very fast these days. And it's getting faster and faster with AI, with technology evolving. And so we needed a method and a system in place that allowed us to, let's say, approve a policy today, be able to modify it a month later, and to immediately then modify the questionnaire, and then immediately allow the real-time PA to be accurate and correct and the right thing to do. And so finally, how do we go about it? We had a formal RFP in place. And our partner Itiliti came out ahead. They were able to do what we needed in terms of manual rule building, so that we weren't relying on generative AI for the QA, for the questionnaire development. We were impressed with their criteria builder tool, and they were able to meet the condition we needed, which was that every single plan in our system be able to get all versions, HTML, the coded policy, the FHIR questionnaire in JSON, and the ability to modify each as needed. And so I'm going to let Michael tell you how it works, and then I'll come back and address questions. Michael?
Thank you, Rob. It's also always great to hear your perspective on the project and the work we've done together. We've really appreciated our working relationship. Okay, I am sharing. Sorry, we had just a quick. For some reason, I'm not able to advance the slides, Casey.
Let me see. Do you want me to share for you,
Yeah,
Michael?
if you would go back to share, and
Okay.
And that'll work just great.
Okay.
Then we'll let you advance the slides.
Which slide are you on?
Next one up, slide 25.
There we go.
There we go. Awesome. Again, thank you, Razia, for that great overview of what we were attempting to accomplish. I'm just going to talk a little bit about the approach we took as we went through that process, and some of the elements of that. So first of all, one of the things we did was we wanted to look upstream from the process of creating a DTR questionnaire. And so as we did that, we looked at what is the process like to actually create a policy in most organizations. And what we have found is that oftentimes policies are written in Microsoft Word. They are then forwarded on to the clinical team, who maybe adds additional comments and red lines and ultimately gives final approval. And then oftentimes a policy is then sent, this is the human readable version of a policy, is sent to the website team, who deploys that new policy on a public website. And some of the challenges with this process is there's a lot of manual elements to that. The policies, as they're deployed to the website, don't necessarily carry with them a lot of metadata in a file-oriented format. The approvals tend to be done via email. The ability to audit changes and compare two documents starts to rely on Microsoft Word's ability to compare two documents. So a lot of external, non-systemic kind of elements. And when we do that with a lot of human processes, we end up with a lack of efficiency. And also it becomes challenging to find the policy that applies for a particular date, because again, the policy in its file format it's not always obvious which file relates to the metadata of the effective date or the end date or version of a policy. And so the first thing we looked at as we looked at creating DTR questionnaires as a concept was to say, well, maybe we can take that PDF document and use that as a source and create the FHIR questionnaire from the PDF document, and then have somebody approve that document manually externally, and then somehow compare the FHIR questionnaire to the source policy. And that just didn't make sense, because it becomes really challenging to compare documents in this manual format or files. And so ultimately, next slide, what we created was an application that manages the policy experience all the way from creation of a policy through the publishing of a policy. And what that process allows us to do is unify the digitized human readable policy and the FHIR questionnaire as as two elements of one entity, that version of a policy. And that one entity, that version of a policy in the system, has an effective date and an end date if there's a future policy that applies. It also has relevance to the particular lines of business or areas, products that the health plan wants that policy to be associated to, as well as other elements like the procedure codes that are related to that policy. So all of those elements, procedure codes, lines of business, etc., are stored in a format that's appropriate for their type of data, which allows that single version of a policy to be easily found. And then as an association to that single version of the policy, the FHIR questionnaire is an offshoot within that version. And I'll show you that in just a minute. But ultimately, by having this in one system that manages approvals of policies, the creation and the workflow around deployment, these policies are much more efficiently shared. Next slide, Casey. And so as we looked to ingest those 700 policies that Blue Cross Blue Shield Association had, we looked to identify the various elements of those policies and store them, as I mentioned, in a format that's relevant to the particular data. And what that means is if you look at this screen, there are different tabs across the screen. Each of those tabs represents a different section of the data within a policy. And so the policy header, as you might imagine, is that text at the top of the policy that's just needs to be stored and shared as text. The criteria tab is a section that stores the typical and or kind of logic, the Boolean logic that's part of a typical human readable policy. And as we go across the different tabs, each of those elements have data in them that is relevant to its appropriate format. So for instance, the attachments tab is where we can attach a document that's relevant to this policy. The required documents is a list of the required documents when a policy is to be submitted. The questionnaire is actually the JSON questionnaire, the JSON FHIR questionnaire. And then as we go across, the last element is a log of all changes of a policy. And so again, this format of this data helps standardize the format of the human readable policy. And I'll show you in a minute how we create the FHIR questionnaire within the criteria tab as a derivative, a component of this version. Another option, if I wanted to, here I could click the preview button, which would show me the human readable version of a policy. So now we've got this policy version in the system in a single instance for both the FHIR questionnaire and the human readable version. If you notice on the left-hand side about the middle of the screen, you see the effective date, and it's a published policy. So what this allows us to do is from a website, now if you go to the next slide, Casey, this is an example of Blue Cross Blue Shield of Alabama's public website that shows where these policies are shown in human readable format. So go to the next slide, Casey. And so within their public website, the policy view of the versions is actually pulling from the Itiliti Health policy database. And you can see that then we have the ability to zoom in on a particular policy based upon keywords, procedure codes, the policy date. Numerous other elements can be added to this screen to allow the user to find the specific human readable version of a policy that they would like to see. Next slide, Casey. And so this is what that version of a policy would look like in the public website. And you see that, it's the typical policy experience that you see in most health plans. But what you don't notice is that behind the scenes, this policy has been dynamically assembled. So the policy metadata at the top comes from the database. That first section of the policy is that initial section of content. The next section of policy is the criteria. And again, they're dynamically assembled when we want to see the human readable version of the policy. Next slide, Casey. So the alternative to viewing the full policy, if we had clicked on that criteria tab in the policy version, what you would then have seen is this screen. And so what we're showing you is on the left side of the screen, this is the human readable portion of the criteria. And the criteria within a policy is typically the section of a policy that drives the FHIR questionnaire. It's the content ultimately that we're trying to get to, or the criteria we're trying to use as the payer is deciding whether or not this prior authorization should be approved. And so, as Razia mentioned, one of the things that's really important to us and our customers is in maintaining a really accurate fidelity to the criteria in the human readable policy, because the health plan, or in this case, the association, has spent a lot of time validating and perfecting the medical criteria, the clinical criteria within this policy. And so what we have done is we've used an algorithm and some technology we call smart phrasing that essentially reads the policy as it's shown, the criteria as it's shown on the left, and converts it into a logical view of the criteria Boolean structure. I'm not showing that on the right screen. I'm showing you the resulting FHIR questionnaire. But essentially what that allows the user to do is the policy writer can edit the policy on the left side, and on the right side of the screen, they see what the technology has interpreted to be the Boolean logic. So for instance, if there's a list of items and it says the patient must meet all of the following, we know that typically that list of items would have a logic behind it in the code that says we need to meet all 5 of these topics. So we allow the policy writer to see a screen that makes it really easy to see that our technology has read what they've intended. We're not changing any of the words on the screen, and we're giving that policy writer the ability to easily see the effect that their human readable policy language has on the logic of that FHIR questionnaire. Once the policy writer is satisfied that the logic follows the language that they have in the human readable policy, they can then click the button called Generate Smart Questionnaire on the upper right-hand corner. And that takes the interpreted logic and creates the FHIR questionnaire file. And that FHIR questionnaire file includes not only the questions, but it also includes a component of the SDC form behavior that's part of the FHIR and Vinci standards that allows the screen to actually know the full logic of the criteria rules. So what that means is, for example, if you look on the right-hand side, that box that says any of the following, about partway down towards the bottom, as the user starts to select the radio buttons underneath that criteria element, the policy writer can actually test the screen and click the various radio buttons and see at what point the system says they have met any of the following, or if it was the case of an all of the following, they would need to click all of the items underneath that hierarchical level to make that rule come true. And so through that, this allows the user, the policy writer, to create the policy using the human readable text, see what it's going to look like in a interpreted technical view, and then generate the smart questionnaire as you see on the right. And that allows this FHIR questionnaire to be created by a non-technical person and tested by a non-technical person. And this is one of the things that we were really striving for in this implementation, was that the association didn't want to have to rely on IT to generate a FHIR questionnaire and then have the policy writers have to test that FHIR questionnaire and see how it compared to the two. They wanted that to all be done in one step with real transparency to the policy writer, so that it really didn't require a technical person to create a FHIR questionnaire. The ultimate outcome on these FHIR questionnaires is that it is really an attestation-based process, meaning that the provider can answer these questions, and through the answering of the questions, the system can know that this prior authorization should be approved. When that FHIR questionnaire is created for the provider, the health plan or the payer has the option to display on the screen to the provider that they have completed the required criteria elements to gain approval for that prior authorization procedure code. Or if the payer wishes, they can rely on, they can make that unavailable to the provider so they can answer the questionnaire, but they don't get to see real time that they will probably get approved. Another feature of these questionnaires is that they they have the ability to capture the attached documents, the document requirements. So from that other screen that we had shown you, there was the ability to say, these are the documents we want when somebody submits a prior authorization for this questionnaire, this procedure code. And those required documents show up on the bottom of the questionnaire inside of the typical workflow for that EMR system. And that allows the payer then, even though there's an attestation-based approach in the submission of the prior auth questionnaire, the payer has the ability to use various tools to compare the FHIR questionnaire answers from the provider to what documents have been attached and potentially audit those attestation-based answers in the future. This process is fully FHIR compliant, and because again we understand all of the logic within the FHIR form of whether or not a prior auth can be approved, this supports a real-time determination. So when the form is filled out and submitted, the receiving pass receiver can look at the data within that FHIR claims bundle and see that the provider has met the criteria for the specific procedure codes listed within that FHIR claims bundle. That means that it can either be automated on point of submission in real time, or a user can review that information in another system, in the utilization management system or otherwise, to make a decision based upon what they see in that information. A little more technical information. We can serve the questionnaire via the $ questionnaire package or the canonical URL. The FHIR questionnaires can be stored within the Itiliti Health FHIR server and queried as a DTR destination, or can be saved in the payer's FHIR server. And then for delegated vendors, we also handle routing for static and adaptive questionnaires, and including the determination guidance calls within the pass submit bundle. Sorry to get a little technical there, but I wanted to make sure we hit on those points for the Da Vinci crew. Next slide. I'm sorry, one more point I want to mention before I get there. A couple of things that are coming in the near future. The questionnaire generation process today will be adding additional data types supported by the structured data SDC logic. We will be further incorporating FHIR path and FHIR queries, as well as CQL data queries. And so that's again all of the future state from a technical perspective. So these are just some payer customer feedback elements regarding the overall structure of being able to combine the creation of the human readable policy and the FHIR questionnaire along with a human readable FHIR questionnaire generation that doesn't require a technologist. So ultimately, some of the key things that we found that the teams really like is being able to integrate these workflows between the different clinical excellence teams that are contributing to the FHIR, to the policies is really helpful, so that more than one person can touch an instance of a policy as it's being authored. It's not having to be shared via email. Because of the tab structure, it really drives a much more consistent formatting and standardization of the human readable policy and makes it easier for the FHIR creation to focus on that criteria section. In the efficiency and simplification area, by not having to go generate HTML style sheets and other things in the background when it comes to sharing those files on a public website, it really significantly reduces the workload of for the team that's distributing these policies. being able to manage the questionnaires and the policies in the same system as one version of a policy is a significant help in avoiding having the policy and the FHIR questionnaire end up in two different states or rules that don't align. Next slide, Casey. Another element that I didn't show you specifically on the screen, but each policy version has procedure codes associated with it. And those procedure codes can also be used within the FHIR questionnaire to align with certain sections of the FHIR questionnaire. And that helps support what a lot of times in the human readable versions of policies, you'll notice that they have multiple sections for different procedures, all kind of buried within the same human readable criteria set. And so by storing those procedure codes as structured data, we can associate the procedure codes with the sections of the FHIR questionnaire and ensure that the provider is only asked to enter the data that applies to that particular section of the FHIR questionnaire, and at the same time maintain a very similar structure to what payers have in their current criteria sections. From a QA perspective, there's a really significant advantage to having the FHIR questionnaire married to the policy criteria. As I showed you again, it's a left side, right side view of the policy criteria and the FHIR questionnaire, which allows the policy writer to easily see when they make a change on the left side, how that's going to be interpreted and shown in the FHIR questionnaire, and then the ability to quality assure or test the logic in that FHIR questionnaire all on the same screen is really powerful for that, the shortening of the time for that QA process. Again, the system supports versions and effective dates of the policy human readable version and the DTR FHIR questionnaire. So that allows, again, that policy writer and the team that's going to control these versions and when they are effective to create those policies, for instance, months in advance. They can create a new version and have it with an effective date of a future date. And now they don't have to do anything to deploy that questionnaire or policy. It's automatically available when that date hits. And so that draft version of a policy, once it's finalized and saved as published, it becomes effective for the effective date of that policy. Next slide. And I think that concludes the Itiliti Health and Blue Cross Blue Shield Association section of the presentation.
Thank you. Really good information. It is fantastic to see not only the partnership that comes together, but the principles that you've established as the framework for all of this, and really creating a paradigm shift from what I can see to fix the plumbing, I think is the term that Raja may have used earlier, of prior authorization. That really it's not, it seems to me like you've taken it not only from this capability of being able to craft the policy information, make it an enhanced user experience in the turning that policy into a questionnaire, but also then to give some flexibility to take it to the next level on how the EHRs may then interact with those questionnaires and the policy sources. So I found this really fascinating and really great to see the capabilities that Itiliti is really advancing through their product stack. And so I know we have some questions, so I'll stop gooing and guying over the demo for today, so to speak. So there are a handful of questions that have come in. So one of them is actually related to something that's not Blue Cross Blue Shield, and so I think it might be good to at least tackle this question that I think really comes back to the local policy kind of dynamic, and that principle of care is local theme that we heard from Raja at the beginning. And so how were non-Blue Cross Blue Shield Association or Blue Plans policies such as that are handled in Medi-Cal or Medicaid handled those, and I think Raja, I guess from a perspective that it's really not at the association level, this might be really much more at the local level. So it might be a functionality aspect, or is there a combination of maybe policy and perspectives from the association's perspective view as well as the technology view from Itiliti? So how would you like to tackle that
So I'll
question?
get us started, and then Michael can correct what I just said. So uh, we, at all times, as I said before, we recognize that the practice of medicine is local. It's very important to us to manage that local nature of the relationships with providers and patients. And so we believe that going forward, not only does the association need the ability to provide machine readable policies and questionnaires, but the local plans do as well. And so in selecting Itiliti as a partner, we did two things. We not only selected them for the central effort, but we also set it up such that if a local plan wanted a partner to develop their own local versions of machine readable policies, that Michael and his team were available to them as an add-on contract. Michael, do you want to add?
Yeah, I think what the questioner might be kind of getting to, which is I really think a really important topic for the industry, is that the the scenario that we've embarked on with Blue Cross Blue Shield Association is one that the association creates these policies and model policy language and has gone through the work to create the FHIR questionnaires and a very effective way to get to those human readable policies. And then multiple downstream Blue Cross Blue Shield plans can leverage those artifacts. So what we didn't talk about is there's a method by where the affiliate Blue Cross Blue Shield plans can take advantage of this work. So think about it that one organization is doing the work and many other organizations can leverage those policies and reuse them. There's also the ability in this structure that we've built out for those downstream plans, which typically happens, to say, you know what, we're going to change the wording on this one policy a little bit. And so the structure that we've created and have deployed allows those downstream plans to make edits and changes to those policies and republish the FHIR questionnaire in that same tool set. So it allows that one organization to do a lot of work and have many other organizations benefit from that. On a very similar note, Medicaid plans, state Medicaid organizations create provider manuals, which typically are the equivalent or have within them the equivalent of the 700 medical policies that a particular payer might want to use. The challenge in the FHIR structure and this initiative is that those policies that are deeply embedded in these provider manuals of the Medicaid plans ultimately need to become FHIR questionnaires similar to what needs to happen for commercial policies. And in a state like Texas, for instance, the state of Texas creates the provider manual, and there are 28 managed care organizations that also want to leverage that provider manual. And if the state doesn't embark on the work of doing those FHIR questionnaires, somebody else has to. In many cases, the individual MCOs in each state are taking on the work of creating those FHIR questionnaires one at a time for each of the 28 MCOs, which really doesn't make a lot of sense, right? So actually, Itiliti Health is working with some states to take the same approach of fix and create those FHIR questionnaires once, create the policy, human readable policy once, and make it easy for the downstream plans to leverage those policies and FHIR questionnaires. So we would welcome any introductions to states because we are embarking on that work, and it's really again, leveraging the exact same structure that we've applied to the Blue Cross Blue Shield Association, with one organization doing the work very efficiently and all the others getting to share in that effort rather than everybody having to do the same amount of effort 28 times, for example, in Texas.
Does sound like the true underpinning spirit of burden reduction, as we call the suite of CRD, DTR, and PAS. So next question, kind of getting into this level of lift and effort. There was a question about how long did it take to create the Blue Cross Blue Shield Association 700 policies and then electronically instantiate them with the DTR. So I'm thinking that's probably there was a bolus of work that was leveraged, but I think from taking it from that point to the process of getting a DTR out the other side of the equation, how long of a process is that?
I can
Well,
maybe
Michael,
start.
if you remember, we started the work in October of last year.
Yeah, well, I want to be, uh, so the entire project is October. I think what we'd like to get very specific in some of the steps. So the actual agreement was signed in December. So we actually started ingesting those policies in January. Um, and just a little bit about the steps. So typically what we do first is we took all of the 700 policies and we compared them in structure, because you're looking for, is there a consistent structure? Do they vary a lot? And again, our goal was not to use AI to convert these into a digital format, because the risk is that AI may change the meaning. We've all seen the sixth finger on an image, or the stories of lawyers that submit briefs that are made up by AI. So we wanted to make sure that we were really crisp. These policies ultimately are going to underpin billions of dollars of transactions. So the critical goal was to take the text of that policy, ingest it into each of those tabs. And so the way that was done was we looked at the 700 policies. We found that there were a few that varied, but for the most part, there was a common format. And we built a routine that could essentially ingest those policies into our structure. That process, there's a process of getting to know each other during the implementation process and explaining how this is all going to work. When we finally do get access to those 700 files, it's a couple of weeks of analysis work to understand the structure. And then there's another phase of building a utility that's going to convert those into that new structure. And that's a week or two long. And then there's the push of a button, which takes all those policies and brings them into the new structure. That is the quick part. The next step is we need to compare, what does that now remanufactured policy look like in comparing it to the starting point. The good news is when we compare the policy as it existed in an HTML format and the policy as it's rendered with the Itiliti Health product, we don't have to read the text, because the text has been brought over verbatim. There is no change to the text, but we have to make sure that the fonts and the colors and the format, tables, all of those things are rendered correctly. And for anybody that's ever uploaded their resume to one of those resume reading websites, you'll know that they always change format just a little bit. It's actually a bit of a science to read human readable files in Word and bring them over into something else and have them a different format show up exactly. So that's where there's a little bit of work where, ultimately a human has to look at the before and after picture and do what we call pixel perfect, I think. Essentially, we're comparing and making sure that the fonts, the colors, the styles are all perfectly aligned. So that's the lift on the initial ingestion. The next step in the process is opening up the criteria tab and seeing how has the technology interpreted that language, all of the following, one of the following, any of the following, and the format of that from right to left. If there's tabs, we need to make sure things are structured correctly. And so again, that's another step. where a human can look at the left side of the screen and look at the right side of the screen and make sure the interpretation is correct. In some cases, the original language didn't match up with the typical phrasing of any of the following. Maybe there was a extra words in that phrase or something. And so the policy writer can go in and adjust that to make sure that the phrasing is consistent to where the interpretation on the right side of the screen is accurate, and then push that button to create the FHIR questionnaire. So each of those two human steps involve a couple of iterations, right? We go through Itiliti Health, verifying the pixel perfect view, and then the customer going back through and looking at those to make sure they are accurate. Similarly, when we get into the FHIR questionnaire, there's an expert that goes through the process the first time, and then a sub-expert. So if we talk about it in total calendar time, we started the entire project in January or late December, and we are in June, and we are about 90% through all of the human readable and FHIR questionnaire conversion. I will say, every time we've done these multiple times. Every time we do them, we get better. So we expect, we have some that are happening now in a matter of 3-4 months rather than the 6 months this project has taken. So
Thank you for
that's a
that.
very long-winded answer.
But I think it helps to understand that and manage people's expectations around that there's a methodology here that you have to follow, and the accuracy is important. And there can be a very big difference between taking policies that were already created and approved, and how from or taking or having to create something from scratch versus trying to take something and then convert it, so that it can be used in a questionnaire. So I appreciate the answer, because I think folks need to understand that there's an investment, to this paradigm shift that's happening. And it's a worthwhile investment.
And there's some good news in that, while Da Vinci and the FHIR requirements lay out a wonderful structure for a very thorough questionnaire process that goes over to the EHR and pulls the data and has all the logic built into it. That's not necessarily required for day one. And so what we do find is sometimes policies don't even have criteria in them. And so what we've done in those cases is we've used a more simplistic questionnaire that maybe asks for a little bit of demographic data about the patient and asks for the provider to attach documents. And that's an acceptable starting point, but it's really important that this now support the evolution to a more rich FHIR questionnaire over time that can be added to or edited in a next version by the typical writer of the policy rather than a technical person.
Got it.
Any other comments on the lift, the amount of time it's taken and the effort, Razia?
No, absolutely, you're right. And it's a learning experience, because typical medical policy teams are not used to this kind of work. And so it's been an amazing collaboration with Itiliti.
So one of the questions we also got, was the following. What do the FHIR JSON artifacts utilize to standardize the logical relationships between the various criteria in the questionnaire and response?
The question is a little bit above my expertise. Again, I think we are using the SDC form behavior, and that's how we incorporate those logic elements between sections. So again, if we display 5 items that are underneath all of the following need to be met, the JSON questionnaire does know that all 5 of those need to be checked in order to meet that hierarchical level of the requirement.
So, Raja, do you have anything you want to add to that? Because I saw that you were.
Oh my God, no.
Okay. All right. Well, we have some related questions. And so this one is actually related, and it's to clarify the presentation. So right now, the SDC style questionnaire are just designed for a human to fill them out, but it sounds like the plan is to introduce queries for structured data in a later phase of the rollout.
Yes. So today, the FHIR questionnaires use an approach that expects a human to answer those questionnaires. And that's a conscious decision because the query capabilities are not really supported thoroughly within the EHR area. And I think that's an evolving area. We are seeing organizations looking to acquire AI tools on the provider side to answer questions rather than having humans answer questions. So I think that's going to be an interesting competition, if we will, between the maturity of EHRs to be able to support queries via CQL or others versus the EHR systems and supporting technologies being able to answer questionnaires using AI.
We need to crawl, then walk, then run. And it sounds like we're all
Exactly,
working on the
exactly.
crawling right now. And so I am excited for the world past 2027 because I think then we'll start to walk, and then we can start to run marathons and let
I,
the technology tools really help automate things. But it does really also take having the right data in the right place in the EHR. So I think that there's going to be some opportunities for enhancing our data capturing to ensure data usability. And I know that we've been talking in the Da Vinci PMO about bringing some of the like the Picky framework and Sequoia's data usability group to the stage. So stay tuned for a future session on that. Also, you might want to check out our Trebuchet educational sessions because I think we're going to also road test those topics initially there. And we do have a few more questions, and I'm loving seeing all these questions coming in from the audience. All right, so how does the FHIR questionnaire and clinical criteria tools, such as like an interqual, work together, or does this take the place of it?
yeah, that's really been an exciting evolution over the last year. I think about a year ago, we saw Interqual and MCG kind of come together on a very similar approach, which is to say that their DTR questionnaires can be an artifact that is queried from their DTR server. So in the case of the Blue Cross Blue Shield Association questionnaires and structure for from a pure Blue Cross Association perspective, this is kind of outside of their realm. But where this applies is where a payer, for instance, might use Interqual for certain questionnaires and the association questionnaires for other questionnaires. There's a couple different options. If an organization strictly uses Interqual, they can ingest the Itiliti Health FHIR questionnaires into the Interqual structure and save them as a FHIR JSON file to be a part of the Interqual workflow, or the Itiliti and Interqual tools can both be DTR destinations, one of whom can be the primary DTR destination and the other can be a subservient, which is essentially proxied. And so that's one of the things that I think is really um, something that a lot of organizations don't understand is that we can either have the FHIR server know which DTR destination holds which procedure codes for which lines of business, or in the case of Itiliti, we can be that primary DTR server that then does know where to go get the FHIR questionnaire from Interqual for certain procedure codes and lines of business and groups, et cetera, or somebody else as we would typically a delegated vendor.
Excellent. Yeah, there are a lot of pieces and parts to be connected, and everybody's architectural decisions will necessitate some reflection on what is the best model to use based upon what you've invested in so far and what kind of vendor stack that you're using. So that was do you have anything to add to that, Rajia? Okay. All right. So let's move on to our next question. Um, so first of all, a big thank you from this questioner. They would like to know, do the attached files start to fall in CDEX area, or does this stay in the DTR and PAS area of FHIR?
Yeah, they do stay in the PAS area of FHIR in this case.
So my thought was that you really don't get into CDEX until you've already passed the DTR phase, and then they've gotten into the PAS phase, and then they say, oh, no, we really think we need something else, and they make a request for that supplemental data. So really the DTR should be the workhorse. CDEX should be the fail safe if something else is determined as being needed, because there, I would imagine, Rajia, that there's a situation where you've got a questionnaire, it meets your policies, but sometimes the scenarios of the in the patient care situation could be unique that would prompt a need for human review, and they might find that there was supplemental data that they would want that may not have been a part of the medical policy questionnaire design in the beginning.
That's right. So I would think of it as adjacent, and in the spirit of creating the least burden for the provider and patient, if that information is accessible in the clinical data exchange realm, then it would be prudent for the organization to try and get that, right? And so, yeah.
Yeah.
Okay.
And similar to what you're describing, Alex, our approach is to be able to ask for those attachments during that FHIR JSON questionnaire so that we can avoid that back end request for more
So if
documentation.
you know that your questionnaire is going to want
Right.
something additional, a lab test, a radiology result, something that you can then at that point say, here's your questionnaire. Here's also a place where you can then give me that supplemental attachment. So you, in essence, I don't know if you're using the CDEX IG for that, or effectively you're using that kind of methodology, because it's not like the CDEX as is written into the
Right.
PAS IG processes. Because you can use CDEX for a lot of different capabilities, not just the PAS part.
Right.
Okay, awesome. All right, so let's see, let's go on to our next question. Um, how do you see the need for questionnaires evolving over time? Do you foresee a world where payers could connect to the EHRs directly, maybe through CDEX, and questionnaires will not be needed?
So I'll give my opinion on this. I think that it at this point the the approach in this world is that the payer needs to have a clarity around what the rules are going to be and how a prior authorization is going to be considered. And the questionnaire is a very effective way to share that with the provider so they have some sense of the expectations. And going to a pure transparent or a pure data transport approach where essentially the provider says, I want to perform this procedure, go look at all the data and see if you agree that I'm ready to do it. That puts the payer back into a position where the rules are kind of invisible to them. And I think it's really important that providers have the ability to know what the rules are as part of this process. There are people that say, well, then the provider can answer the questions in a way to get a prior authorization every time. But in that scenario, that would be committing fraud, right? If they're answering questions in the wrong way. So the current structure allows for the provider to attest that they've met certain requirements, attach the documents to prove it, allows the payer to then validate that that's the case. And personally, I think that's a very efficient process. But I'd love to hear your thoughts, Razia, on what you think about a workflow where there's no policy questionnaire. There's just the payer being able to reach into the EHR and grab data and make a decision.
I mean, that would be ideal, right? Because then we really speed things up. But the reality is that there'll probably be, I think the questionnaires will shrink, the need for it will shrink, but there'll always be some unstructured data or some interpretation that the pull cannot do. So, for example, has the person failed a certain amount of conservative therapy? That's not something that the data can pull, or at least I don't understand how that would happen unless you just define those very specific terms of, in this particular condition, this is the conservative therapy, this is how we define it. So I think you're right. I think there's going to be a need to continue, but just probably will shrink.
I also think from my own perspective, I've observed historical dynamic related to trust between payers and providers, and I've felt some sense of providers may not always want to just enable a payer system to reach in and pull data out systematically. But I do think as we're becoming more transparent, we have more auditable systems, as enabled through exchange APIs like FHIR, we can start to constrain those aspects. But I think that's a ways off, till we would be there. So we have another question. If FHIR questionnaires require any update, then will it change the policy doc? I'm thinking it's maybe the other way around.
Yeah, it's a great question, and it's kind of that chicken and an egg question, right? Which comes first? Somebody wants to change the FHIR questionnaire, they want to change the policy doc. I think it's a great question because it leads to the idea that I've tried to describe, which is when a user wants to change the policy doc or the FHIR questionnaire, they should make sure both of those are edited or changed because they have to be synchronized, right? You wouldn't want to change the FHIR questionnaire without having it be married to the policy document, and anything you say. For instance, if I say I want one of the following changes to two of the following, I want to make sure it says that in the policy document and that the FHIR questionnaire uses that same logic, and that change to those two documents happens on the same effective date and for all people that need to see that change. And that's why it's so important that these two concepts be married together in one system. We see a lot of people thinking about maybe using AI to create the FHIR questionnaire, but then how do you maintain these two files in separate systems, and what does that workflow look like? And then how do you validate that FHIR questionnaire matches the logic of the policy? So any comments on that, Roz?
Yeah, if I could just add, obviously, from what's primary and what drives, it's the policy that drives, right? But the reality is that we're learning that the policies were written for an era for human interpretation. They were not written for machine readable, computable files. And so the feedback loop is really important. If the questionnaire doesn't work, the policy team needs to get the feedback and they need to then change the language. But the document that's primary, that drives the rule, has to be the policy, because that's what is contractually required. That's what's going to be held up if things didn't go right, or in an appeal scenario, not that the questionnaire got it wrong.
So it's also back to that concept of auditability, like traceability and auditability, to ensure that you've got the compliance, because it really does start all the way back the beginning of the process. That's that plan design with an employer or a group, commercial product line that you need to really ensure is fulfilled.
Right. Now, as I was saying, there's been a huge amount of learning because the feedback loop is the way we write doesn't necessarily translate to algorithmic thinking. And so we're having to think about, what would it mean if it was converted to a questionnaire? We never had to do that before. So that's been great.
And that's what's really exciting about putting those two things side by side on the
Yeah.
screen, because it allows that policy writer who may have written a policy one way in the past to see, oh, when that's turned into a questionnaire, I'm going to want to restructure that a little bit so that it makes sense in both formats.
One of the things I'm loving about this conversation is that we've been pulling out various pieces of the paradigm shifts that need to happen from the technology stacks, the design of the business processes and legal documents that interact with those, probably the staff time to think about things in a different way because the tools that are being enabled through these implementation guides are really transforming the way work is being done. There's an initial investment, but we're really striving for reduced burden across the ecosystem and ultimately in better support of that patient care. And by having that DTR so automated, you're really enabling that path to getting that scheduled care to occur, happening all that much faster. So it's been really fantastic to hear about all the pieces of the puzzle and to have the details around how DTR really is creating much more of a paradigm shift to not just the plumbing, but also to all the things that enable the water to flow, so to speak. So I am not seeing any more questions. This has been a great session today, and I really want to thank Raja and Michael for being here and sharing their Blue Cross Blue Shield Association and Itiliti Health capabilities and experiences. Lessons like this help others be better and wiser in their own journeys to pick up the implementation guides, whether it's for their own use or in a compliance effort. So we look forward to hearing more future successes from the team and give everybody back a few minutes of their day. And we look forward to seeing everyone at our August roundtable as we do give everybody July off during the summer hiatus. So thanks and have a great balance of your day.
Thank you very much.
Thanks.